the back of the head, or posterior occipital protuberance, POP, or what else did somebody say? Okay, greater occipital protuberance. Okay, the bump. And typically you're starting with 2 fingers, 1 on each side. You're compressing into the skull. You're separating your fingers, I'm going to exaggerate it, and then you're shearing. 1 down, 1 up, and then the opposite. You're doing that because I think it's easier to find releases. Oftentimes when people describe this technique, they don't talk about specifically that. They say, I put my 2 fingers on there and I wait for it to release. Well, that's a little hard when you have no idea what that feels like, right? So I direct you a little bit more. So your small group instructor might have had slightly different words to tell you that. That's one of the reasons why we did it in front of the class for everybody at the same time, to make sure we all heard the same words. Okay? Compress, 2 middle fingers, compress into the skull, separate your fingers, shear the tissues, 1 away from you, 1 towards you, and then the opposite. You take it which way? How it wants to go or how it doesn't want to go? How it wants to go. Always indirect. Take it where it wants to go. And you wait for that to release. That will take anywhere from immediately to 20 seconds. If you don't feel it after 20 seconds, move on, because it probably happened and you missed it. Or you can take your hands out, put your hands back on, and recheck it again. Kind of re-feel and see, it doesn't really feel like it's bad now.
Is it taken in the same direction? Just hold it there and hold it down?
Yeah, you take it in the same direction, you hold it there, and what you're doing is, as they're breathing and as their motion is happening, it'll tend to soften, and you'll feel like your fingers are floating further apart. So it's that softening you're feeling for. Then you're going to move on to occipital sinus. So from there you move inferior. So 4 fingers on either side. So you're below the inion towards the foramen magnum. 4 fingers on either side. You're compressing into the skull with all 4 fingers, separating your fingers to get apart, and then you're shearing the tissues again. You're waiting for a release. Anywhere from immediate to 20 seconds or so later. Okay. The next one is transverse. So you go back up to inion, and it's either right next to inion or just above inion. You kind of feel, and there's a more firmer spot on the skull there. The important part about this is my fingers are all in line across the skull. I don't have them like this anymore. Okay? They're in line horizontally across the skull. Then what we're doing here is we're really more of like balancing. You know, if you were trying to balance something on your finger and you had to kind of move to keep it over you, it's the same sort of thing, but instead of moving your finger, you're compressing up or relaxing a little bit. The firmer the tissues, the harder you're pushing. So, without driving your fingers through your skull. So, if you get a lot of pushback, you push harder towards it. And then your hands in general slide apart just a little. This is a huge exaggeration. But if you can't feel this so well, then this you should be able to feel. And you wait for that release. Softening. Okay? This is a really important part of the skull because this is where the 2 layers of the tentorium come together. The layer that sits on top of the cerebellum and the layer that sits below the cerebrum of the brain. So it kind of gives you this window into the membranous component of the skull. So as you learn more about cranial, if you have that desire to do, some of us talk about bony cranial, which is strain patterns and sutural restrictions. Some of us talk about membranous cranial, which is really feeling for the membranes and how the forces are in there, which also has to do with strain patterns. And then other people talk about fluid cranial, or how the motion of the fluid moves within there. And you'll learn more about that if you do the elective. I think you guys have an elective, I can't tell you for sure though. Okay, so then the next part of that is, and by elective I mean that it's a forced elective, you pick one or the other, so it's not really an elective. It's a selective, you choose one or the other, so not the whole class does the same thing, and I think we're still doing that with your class. So where do I go after transverse? Sagittal suture. Now remember, sagittal suture starts here at lambda. You're okay to start lower than that, even though you're not on a suture line, because the sagittal, the venous, yeah, in the venous, the superior sagittal sinus Thank you. That's not where's the other word. Comes down a little lower because it comes down to that confluence of sinus. Okay, so you can start a little lower than that. Typically, in order to get to there, you have to take the patient's head and crank them up a little bit and get your wrist underneath kind of bent, and then you start your motions. We often teach you, or we typically teach you with your thumbs crossed over, so you're really letting those two bones separate from each other, or letting the force. What happens is as the head's sitting on your thumbs, it kind of just allows them to, with the force of gravity, so you don't have to use too much force to do that. My thumbs are really small, so I tend to put my thumbs on either side, and I do what I did everywhere else. I compress in, I separate apart, and I shear. When your thumbs are crossed, it's harder to do that shearing because you'll run into the other thumb at some point. So you're going to basically say you walk up the sagittal suture. And the sagittal suture, you can literally walk up, because Dr. Francisco showed us that. Most people do one spot, get a release, move up 1/2 to 3/4 of an inch, do the next spot, get a release, and move up. If the patient's going to have any pain during this whole venous sinus drainage, it's typically along the sagittal suture. Usually it's tolerable, but they have they're compelled to tell you about it. Usually it's tolerable. If it's not, you just move your fingers up or down a little bit and continue from there. Oftentimes, if they can tolerate it, the pressure goes away and they feel much better. All right? You walk up. Now remember, the hairline is about here, and the frontal bone comes to here. So as you come up to the sagittal suture, then you're going to switch and do 2 hands for the metopic suture. Now, not everybody has a metopic suture in the middle of the frontal bone. Some people do, some people don't. Most people don't. But as your patient's laying in front of you, you have your hands across there, and the same deal. Compress, separate, shear. Take it to where it wants to go. And then when you reevaluate the head after you do that, then it should be a much easier motion. So, for example, if you picked this one as your demonstration technique, you can actually pick up the skull and say, this is what I would do. I would put 2 fingers here, I would compress, I would compress into the skull, I would distract them apart, I would shear those tissues, wait for relief, and then I would move on to the occipital sinus. And they might say, well, what's a release feel like? And it's going to be a softening or a release of those tissues. Make sense? Then you do occipital sinus, and you'll have to show where that is, show your hand placement, transverse sinus, then sagittal suture, walk up that, and then metopic suture on the frontal bone. Cool? Alright, parietal lift. We're just doing parietal lift and not, frontal and parietal lift. We also showed you a frontal spread. You don't have to worry about that. So the frontal lift, we basically want to grab onto the frontal bone. So you can feel right behind the eye socket, you have a little ledge there. That's where you want to get your hypothenar eminence. And you want to get your hypothenar eminence on the other side. I'll try to lift him up so you can all see. Okay? I don't want to be on the sphenoid. I want to be just anterior to the sphenoid onto the frontal bone. I'm going to have my fingers, you can cross your fingers like this, interlace them. For me, my hands are really small, so I typically just keep them up away from each other, because when I do this, I feel like I'm really cranking their head medially, and I don't want to give them that much pressure. You're really doing it so you get traction on that bone. All right? Typically, your elbows are out, and you're going to lift towards the ceiling. As you get more finesse in what you do, sometimes you'll lift one side towards you and sometimes the other. But for today, for tomorrow, you're lifting straight up towards the ceiling. You're trying to lift that frontal bone off the parietal bone and the sphenoid bone. Alright? So, when you do that, you may be doing a slight amount of internal rotation. If you could avoid talking about internal and external rotation, I would suggest you do that. I won't have to do that. Parietal bones, or parietal lift. Oh yes, Thomas.
And that's kind of a little tangent, but like, can you just show us one more time, just show me one more time, how do you not this, but how do you just hold the hands when you check for flexion extension? I remember you had to put one.
Yeah.
On, it's kind of,
when you check for flexion
yeah.
extension, you basically have 2 fingers back towards the occiput. So it's 2 fingers behind the ear, 2 fingers in front of the ear. You really want to be on the sphenoid bone and on the occiput bone. You can see even on this skull, I have great difficulty getting there.
Okay.
So for me, with my small hand, I'm typically on the sphenoid and inferring what the occiput does. So I'm a little higher than the occiput. If I need to, I'll switch into a handhold like this. But 2 fingers in front, 2 fingers behind is going to be your basic handhold for which we probably won't ask you otherwise. If they think you don't know anything, they might ask you. It's not on the form. Okay? Frontal lift, you want to get on the frontal bone. You don't want to be on the temporal bone. You want to be above the temporal bone. So if you feel on the side of your head, if you go right above your ear, that's still your temporal bone. So you want to go kind of the next ledge up from there. So it's almost as superior as you can get on the head without falling off of it. And it's kind of like a little handle there, right? On both sides. This dude's going to fall apart. All right. So my hands are on here. My thumbs are typically crossed over. They don't need to be crossed over. They're not really pushing on the skull. They're really there as a leverage point, so you have something to leverage off of. And my motion is going to be like this. So what kind of motion is that for the parietal bones? External rotation or internal rotation? External rotation. It's opening that up. So that external rotation you get in there is like the wings of the DeLorean or the doors of the DeLorean opening up. Okay? That's external rotation of the parietal bones. And if at all other than CV4, your preference is always to move in external rotation. External rotation of the paired bones will go with flexion or extension? Flexion. Flexion gets fuller. The wings of the DeLorean get fuller, so those go together. Get it? It's not really wings, they're doors. Got it?
Will you say that one more time?
Yeah.
Which way they go?
It goes, when you're doing this technique, you're causing external rotation of the paired bones, and external rotation of any paired bone goes with flexion, because it's fuller.
Doesn't work.
Yep, you can't put the E's together on this one.
So you just showed us parietal lift?
Yep.
I thought parietal lift could we have to sit here the same and there's
No, what you're thinking of is the frontal strip. They were similar. It was what we showed you was like this. Okay.
Yeah.
And we lifted with these.
Yeah.
We lifted with these, and we kind of compressed with these, which would be really flexion of that. External rotation of that also. So the frontal lift is really more towards internal rotation, but I don't because you're not internally rotating it much, you're really just grabbing on and lifting. So it's not really either.
Show the parietal one more time.
Yeah. Okay, so again, the parietal lift, you want to make sure that you get off the temporal. You want to slide up to you're almost falling off the skull, and then you're going to put 4 fingers on each side. And your fingers are typically, your thumbs are typically crossed over, and that's really more of a leverage. They're not pushing onto the skull. It's really more of leveraging your hands off each other. You're going to compress gently, but you're going to lift. So your idea isn't you're taking these 2 bones and you're doing this and lifting. You're just grabbing onto them and you're lifting. So in your mind, you think of them lifting like this. Okay? Good so far? Yes, Ron?
And that's not be the treatment. Okay, I guess my question is, if you would ask us, like, okay, how does like lateral, dysfunction feels like, any of the ones you have mentioned? Are we going to be asked how to treat every individual one, or is the only one we have to worry about is the,
you have cards. You have in this